Hey guys, welcome to Topics in Medicine. Today, let's talk about syphilis. And no, I did not say this, Phyllis. Let's talk about syphilis. So a little history and epidemiology for you. There's clear documentation of syphilis's existence in the pre-Columbian New World, and there's scattered evidence of its existence in the pre-Columbus Europe. However, it is commonly accepted that the disease was transported from the New World by Columbus's crew at the end of the 15th century, and it wreaked absolute havoc in Europe. Interestingly, Italy, Germany, and the UK, they all called syphilis the, quote, French disease. The French called it the, quote, Italian disease. The Russians called it, quote, the Polish disease, and the Polish called it, quote, the German disease. So clearly, nobody really had any idea back then where it was coming from. We are seeing record number of cases in recent years, and I do have some epidemiology listed on the screen if you're into that kind of stuff. The biggest thing here is that there's a huge HIV co-infection risk in the MSM community, so men who have sex with men. So the HIV co-infection rate is around 47%, so that is very high. Also, anywhere from 30 to 60% of anyone that's exposed to a primary or a secondary lesion will also go on to get the disease themselves. So syphilis is caused by the highly motile spirochete, Treponema pallidum, which is a bacterium that cannot be cultured in the lab. So that makes diagnosis a little more tricky, which we'll talk about here in a bit. Humans are the only known reservoir, and it grows relatively slow with a similar doubling time as other spirochete infections like Lyme disease. The spirochete is spread through the mucous membranes by direct sexual contact with a primary or a secondary lesion. This includes kissing or oral sex, so not just genital to genital contact. It can also be spread from mother to baby in pregnancy, so it is super important to screen everyone for syphilis who is pregnant. So syphilis presents differently depending on its stage. So the primary stage manifests about 3 weeks after infection. It classically presents as a single painless ulcer, also called a chancre. This chancre usually begins as a papule on the infected area, whether that be the genitals or some other mucous membranes, and develops into that painless ulcer over several days. So clinically, it's not always painless, and it's not always going to be a single finding, and patients with HIV are going to be the ones that tend to have multiple lesions during the primary stage. But on board exams, if you see a painless ulcer on the genitals, it will almost certainly be primary syphilis. Another chancre location it's often missed in females is on the cervix. So if you happen to see one during a routine exam or while you're looking for other STDs in a high-risk patient, do not ignore it, even if it's not causing any pain or any irritation. So here we can see these painless ulcers. Here's on the lips, the labia minora and the majora, and on the perineum. The secondary stage presents weeks to months after the chancre dissipates. It generally appears with a multitude of constitutional symptoms, and these constitutional symptoms are highly variable. So on your board exams, look for derm findings like symmetric macular or papular eruptions involving the entire trunk and the extremities, specifically involving both the hands and the feet. So board exams also love to point out patchy alopecia. They describe the hair as moth-eaten, and they also love to point out condyloma lata as findings for secondary syphilis. So important distinction here, condyloma lata is not going to be described as having cauliflower appearance as it is described in condyloma acuminata infections, which are our genital wart infections that are caused by HPV 6 or 11. So these condyloma lata and secondary syphilis are entirely different. They will be described as flat, they may be described as velvety, and they may be described as moist. And I have a picture on the next slide for you. So other non-specific findings of lymphadenopathy, fever, general malaise may also be present with secondary syphilis. So here we can see this, quote, moth-eaten patchy alopecia. We also see a diffuse and asymmetric papular rash on the trunk, also over here on the feet. This is a great example over here of condyloma lata, which I'm sure if you were to touch it would feel velvety and moist, but it does look distinctively different from genital warts. During the latent phase, patients will still have serological proof of infection if they're tested. However, they will be asymptomatic entirely. So I use the WHO or the World Health Organization criteria to break it into either early latent, which is within 2 years of initial infection, or late latent, which is after 2 years of infection. There are other definitions out there, like the CDC's definition. It uses 1 year, but again, I like to use the WHO, which is 2 years. I find it to be a little more accurate. So during the early latent phase, so that is within the first 2 years of infection, they are still very contagious. These patients are very contagious. And this is completely different from late latent, which is after 2 years of initial infection. These patients are less infectious. Doesn't mean they're entirely non-infectious, but for the most part, a lot of them are not going to be spreading it to their partners. Pregnant women, however, can still infect their baby and cause congenital syphilis up to 4 years after infection, so they fit in their own category. Tertiary syphilis presents years after the initial infection, and it can be divided into cardiovascular syphilis, gummatous syphilis, or the more commonly seen neurosyphilis. Neurosyphilis specifically is most common in HIV-positive patients, and this will present on board exams with some combination of symptoms related to tabes dorsalis, which is a slow degenerative demyelination process of the dorsal root ganglion. So tabes dorsalis presents with ataxia, general paresis, Argyll-Robertson pupils, which are bilaterally small pupils that do not constrict to light, and Charcot joints, which are bone and joint changes that occur secondary to sensory loss. So you may see cardiovascular changes that are specific to the aorta, or you may see gummatous formations, or these non-cancerous tissue growths on the skin, but these are more rare, and they're generally not seen on board exams. So here's a fun mnemonic for you for tabes dorsalis, if you like those, but really just think neurodegenerative changes and think of those buzzwords like Charcot joints, which is also pictured right here, or Argyll-Robertson pupils, those bilaterally constricted and non-reactive pupils. And here we also see some gummatous changes. So think of that word gummatous when you're taking your boards, but keep in mind that those are more rare. So when looking at a baby that you might think that has congenital syphilis, so the most specific finding to look for is what's called Hutchinson's triad. There were other non-specific findings, but look for Hutchinson's triad. So Hutchinson's triad is a triad of symptoms involving the eyes, the ears, and the teeth. So over here on this slide, we can see interstitial keratitis, which is the eyes portion of Hutchinson's triad. And then we can also see this characteristic triangular appearance of the teeth, which is what's called Hutchinson's teeth. And then not pictured here is sensory neural hearing loss, which is that last leg of that eyes, ears, and teeth triad that make up Hutchinson's triad. So I was always super confused on how to test for syphilis, so I'll try and clear up some common misconceptions here. So we can test for syphilis 2 ways, serologically or using the blood. We can use either a non-treponemal antigen test or with a treponemal-specific antigen test. So the 2 biggest non-treponemal tests are the RPR and the VDRL tests. So these are quantitative tests that are cheap and they're usually easy to obtain, but they have a higher number of false positives because they are not super specific to syphilis. So we use these non-treponemal specific tests as our initial screening modalities, or because like I said, it's a quantitative test, we can quantify a response to our treatment to see, 6 months or 12 months after our treatment, whether we got a significant response and the infection has gone away and it has not just gone latent. The treponemal specific tests are qualitative, so they're not quantitative. They can only be a yes or a no, and they're historically more expensive and harder to obtain, and thus we save those for confirming the diagnosis. These treponemal specific tests are positive for life. They tend to be positive for life. And so they're not going to be great for patients that have a prior treponema infection because, again, they are going to be positive for life. So once they test positive once, they're going to stay positive for their life. So the big treponema specific tests are the FTA-ABS test or the TPEIA test. I'm not even going to talk about the fluorescent antibody test. It's actually no longer recommended because it's difficult to perform. It had to do with tagging antibodies with this fluorescent light, but we're not even going to go into that. It's not recommended anymore. So general flow. If it's the first suspected infection, you screen with a non-treponemal test like your RPR, and you confirm with a treponemal specific test like the FTA-ABS. If they have a prior syphilitic infection, you just flip the order. So you do the TREP-specific test before you do your non-TREP test. And of course, use your clinical judgment because those cases tend to be a little trickier. If you suspect neurosyphilis, you need to get an LP or a lumbar puncture with your blood test. And on your LP, you're going to be looking for elevated white blood cells and elevated proteins. Treatment for all stages of syphilis is going to be penicillin. The formulation of it is going to be a little different. So specifically, if they have primary, secondary, or early latent, we will use IM or intramuscular PENG, benzathine, and we will use one dose. If that patient has late latent or tertiary syphilis, we will again use IM, intramuscular PENG, penicillin G, benzathine. But we are going to be doing that for 3 doses. These 3 doses are given Q1 week. So 1 dose each week for 3 weeks. The benzathine formulary makes the penicillin release a lot slower, which is why we can give it Q1 week for 3 weeks or 3 doses. With neurosyphilis, we use an IV penicillin drip. We're going to use that for 2 weeks. So these patients are going to be hospitalized. All right, so one of my favorite stories in medicine has to do with this moldy cantaloupe picture that's on here. So before synthetic variations of penicillin were derived, virtually all penicillin used therapeutically could be traced back to a single penicillin colony found on a moldy cantaloupe in a grocery store in Illinois in 1946. So researchers, they scraped off the mold, they grew large colonies of what would later become the penicillin drug, and eventually that would go on to save millions of lives, especially post-World War II. And then those researchers ate the non-moldy bits of that cantaloupe. And I absolutely love that story. So our main education points for syphilis are going to be that we need to report all cases to the public health department. We also need to offer partner screening and empiric antibiotics to partners of patients that test positive. We need to also test for HIV co-infections. I mean, in all patients, but especially in the MSM community because the co-infection rate, like I said earlier, is close to 47%. We also need to make sure that we get a follow-up non-TREP test, so that's our RPR test, 6 and 12 months post-infection to look for antigen clearance. And as always, with all of our patients, we need to promote safe sex practices. So the main points of syphilis here, just all summed up in 2 or 3 sentences. Syphilis, it's a spirochete. It cannot be cultured. It presents differently based on its staging. Know those stages, primary, secondary, latent, and tertiary. We diagnose in most patients with a non-TREP test like an RPR, and we confirm with a treponemal specific test like the FTA-ABS. All stages are treated with penicillin, but the formulation and the route may be a little different. All right, and here are my sources.